lymph nodes. So,
Yes, sir.
what are the anatomical distribution of lymph nodes which are draining stomach?
So the lymph nodes that are draining stomach are divided into 16 lymph node stations, sir. Uh, these are so, so these are when we talk about, sir, with respect to resection, D1, D2, and D3. D1 is generally considered up till lymph node station 6, sir, which are generally around the celiac axis, sir. And so the
No,
D2.
not celiac axis, not exactly celiac axis.
Uh,
What are these 1 to 6 nodes? These are roughly described as perigastric nodes.
Perigastric nodes, yeah.
So these are along where?
Uh,
If you talk of 1, 2, 3, 4, 5, 6,
yes, sir.
1, 2 is paracardiac.
Paracardiac, sir.
And 3 is?
3 is along the lesser curvature, sir.
Yes.
4
And
is 4A and 4B, that is short gastric, and left gastroepiploic, sir.
yeah.
And so 4D is right gastroepiploic.
Yes. And 5 and
so
6.
5 is suprapyloric and 6 is infrapyloric.
Yeah. So these are the basically perigastric nodes included in the D1 resection.
Yes, sir.
And what are the next tier of nodes?
So then the D2, so the D2 is up till, it's considered up till the 12th station, sir. So 12A. In this case, sir, the number 7, the station 7 is left gastric. 8A, 8A and B is the anterior common hepatic and the posterior common hepatic. 9 is celiac artery. 10 is splenic hilum.
Yes.
Then, sir, 11 is the splenic lymph nodes. And 12, sir, A and B. A is left hepatoduodenal.
Yeah. So these are the lymph nodes included in D2 gastrectomy. Apart from this, there are other lymph node stations like.
So, like retropancreatic. So 13 is retropancreatic. 14 is along the superior mesenteric artery and vein. Sir, 15 is middle colic, and 16 are the para-aortic nodes, sir.
Yeah. And then some infradiaphragmatic node along the esophageal hiatus. Okay.
Yes, sir.
17 and 18 areas of nodes.
Yes, sir.
Okay.
Yes, sir.
Dr. Basu has joined?
No, sir, he hasn't joined yet.
Okay, then. So these are the lymph node stations in the stomach, and stomach has got a rich lymphatic plexus.
Yes, sir.
And Dr. Basu has joined.
Yes, sir.
Good morning, Dr. Basu.
So he's connecting to the audio.
Yeah. Okay, okay.
Makhanda, good morning.
Yeah, good morning, Dr. Basu. I just asked Milind what are the different lymph node stations in the stomach. So you could say that there are lymph nodes which include D1, which includes 1 to 6. And in D2 dissection, you use resect lymph nodes from 7 to 11 and sometimes 12A. So he has described the nodes. So now we can start the exam part.
Yes. Yes.
Steps of
yes. Yes.
D2.
Yes. So Milind, please start.
Good morning, sir.
What are the steps of D2? You got a card in the exam. Steps of D2 gastrectomy.
Yes, sir.
What do you mean by D2 gastrectomy?
Sir, D2 gastrectomy, when we say D2 gastrectomy, it is we are mentioning two things here. One is the gastrectomy part and one is the D2, which indicates the extent of the lymphadenectomy. So the gastrectomy part is would depend it would depend on the indication for the D2 gastrectomy, and it is usually for the gastric carcinomas. So the extent would be from the pylorus up till 6 centimeters proximal to the proximal margin of the growth. That is the gastrectomy part, sir. And the D2 part would be the lymphadenectomy, sir, which would be involving, sir, stations 1 to up till stations 11 or 12.
And in addition to this, what else you take? Apart from lymph node, stomach, and something, some other structure also included in the resection.
Splenic.
No, spleen is not routine now in D2 gastrectomy.
Yes.
Greater omentum.
Yes, greater.
The whole of greater omentum and the lesser omentum.
Now, Milind,
Yes, sir.
Before starting your proper steps, you have to be clear where to do your D0, D1, and D2 gastrectomy, right? In NCCN guidelines, if you follow, then if it is an advanced disease, locally advanced disease, which is incurable, but there is bleeding or obstruction, you can do only gastrectomy. That is a D0, no lymph node dissections.
Palliative gastrectomy.
Okay,
Number one. Number two, whenever this is a localized growth, as NCCN recommends, that is a D1 or D1 plus.
Okay, sir.
Right? Because in Western populations, they show their various I think the publications that there is no difference between D1 D2, but overall if you see in the East Asia and all those things, everyone recommends when a localized carcinoma, this D2 should be done. That's all. Okay. So we'll later explain what is D1, what is D1 plus, and D2. Now you will discuss the D2. Right. Start.
Steps.
Sir, for D2 gastrectomy, sir, first of all, the anesthesia. So patient would
no. Straight in the incision.
Okay, sir. So the incision would be a midline incision, sir, which would start from the xiphisternum and it would extend halfway between the umbilicus and the symphysis pubis, sir. And the skin and the subcutaneous tissue will incise along the same line.
Okay, you have done laparotomy now.
Okay, sir. So then after the if you've done the laparotomy, sir, then we would assess the lymph node station, sir. We would assess the site of the the growth, and we would also assess the lymph node involved, the number of the lymph nodes that are involved, and whether they are mobile or fixed.
No, number of the lymph node you cannot assess macroscopically. Number of the lymph nodes, the station you can assess, number of nodes.
And the extent, that means the lymph is fixed or not.
Now, what is the most important thing? First, you see.
So first, as soon as we enter the abdomen, we will check the abdomen. We will check the abdomen for any signs of metastasis, sir. We will check whether there is any ascites. We will check whether there is any liver deposits. We'll check whether there are any peritoneal deposits, and we will check the pelvis.
So this is important step because nowadays it is said that radiology is better than your eyes. So only thing is that very small liver metastasis and the peritoneal deposit, they are usually missed in even the good quality of CT. So these are the 2 points you look for, not the obvious metastasis or ascites. It is easily recognized. Sorry, it is easily can be seen by your previous good CT scan or like that. So these 2 points are very important: small liver metastasis and the peritoneal deposits. So here the role of diagnostic laparoscopy come. Do you routinely do the diagnostic laparoscopy before operation? That is important.
Okay.
What is the current recommendation?
Yes.
So if in current recommendation, so if the diagnosis is certain, sir, if you've taken or if you've already taken a upper GI biopsy, and sir, it depends on the sir indication. If the gastric carcinoma is associated with the gastric outlet obstruction, and we need to do a drainage procedure even if the resection is not possible, sir, then we would directly go for we will directly go for a laparotomy, sir. Otherwise, we would go for a diagnostic laparoscopy first.
So see, the routine diagnostic laparoscopy is not done in all cases. Only it is recommended in some specialized in some centers. They are protocol wise that early gastric carcinoma, that is if it is operable or not, then the diagnostic laparoscopy is routinely done. Otherwise, straightway you have to go for laparotomy or laparoscopy, whatever your choice.
And in particular, people who are in favor of giving neoadjuvant treatment for T3, T4
Yes.
lesion, in that case, they prefer to do a diagnostic laparoscopy, because in sometimes in CT also, you cannot exactly do a T staging. There may be some difference in laparoscopy finding. So in that case, if the regime is to give neoadjuvant chemotherapy for locally advanced disease, then people are doing diagnostic laparoscopy.
Yes, sir. Yes, sir. And also particularly in G junction growth, particularly in G.
Okay. Now then you have done a diagnostic laparoscopy, no distant spread, you have converted to open. So what are the things you look for? You said distant metastasis like small peritoneal nodules, you can see in laparoscopy or on open. And then number of lymph nodes are not being counted once you go in.
Yes, so we will check for the
You
stations.
see that which lymph nodes are involved and whether lymph nodes are fixed or not. You see, the fixed lymph node is also a criteria to say that a curative resection is not feasible.
Yes, sir. Yes, sir. So we would also assess the growth, sir. We would also assess the growth, whether whether there is any local involvement, whether there is any serosal involvement, what is the size, the depth of invasion, and we would also look at the adjacent structures, sir.
Okay, fine. Consider that is a resectable growth, no
Yes,
distant spread. You are going for a curative D2 gastrectomy. What are the things you do and what are the sequential steps?
So we start with we first divide the greater omentum from the transverse mesocolon, sir. And so this we do, we enter this is done by a sharp dissection, and we try to go into the bloodless plane in the transverse mesocolon, sir.
Transverse colon, not mesocolon. Greater omentum is attached to the transverse colon along the tinea colon. Mesocolon come afterwards. Once you incise the whole of greater omentum on transverse colon, the next deeper layer is the superior leaf of transverse mesocolon. You take that?
Yes, sir. So we enter the bloodless plane and we dissect it. So so after that, sir, then so once we've cleared that, sir, while clearing this, we might encounter the gastrocolic vein, sir, that has to be ligated.
Gastroepiploic, not colic. Gastroepiploic.
So then we come to the division of the gastroepiploic vessel, sir. This is along the this will be along the greater curvature, and once so we and so this is usually when we dissect the greater omentum, along when we lift it, the gastroepiploic pedicle will be there, and we would ligate it. So then we would, then depending on the proximal extent of
Milind, have you seen D2 gastrectomy? Person? No.
No,
so there you should tell like this, so the examiner will understand that you have at least once followed the D2 gastrectomy. So whenever you open the lesser sac by this thing, dismantling this transverse from the mesentery, from the transverse colon, right from the hepatic flexure up to the splenic flexure. So then you pull the stomach upwards, and your assistant will pull the transverse colon downwards, so that it exposes the lower border of the stomach and the upper border of the pancreas. The upper border of the pancreas is very, very important because there is three important structure: your gastroepiploic vein, your middle colic vein, and also the superior mesenteric vein. That is, you have to go identify, and then you ligate the gastroepiploic vein, so that lymph node and fatty tissues you will remove. This is the proper way. Otherwise, you will injure blindly if you ligate the gastroepiploic vein. This is important. And for which station you will remove there?
Sir, here we'll remove station
What?
Station 4, sir. Station 4.
No.
The right gastroepiploic, sir.
No. This is not station 4. Station 4 according along the greater curvature.
Yeah.
Greater curvature.
Sir, station 5. So station 6, intrapyloric.
Yes. Station 6. Yes.
Station 6, intrapyloric, sir.
Yes.
And then you will dissect the fascia over the pancreas, so that you clearly see the GDA, and then from GDA you will ligate the gastroepiploic artery.
Right gastroepiploic.
Right. That is your way of doing this thing.
Yes,
so right gastroepiploic done, then.
So then we go to the left gastroepiploic, sir. Now the extent from which the left gastroepiploic is ligated depends on the proximal extent of our resection, sir. So we have to take a 6 centimeter margin from the proximal edge of our growth, and this will decide how proximally we ligate the left gastroepiploic. Sir, if the proximal margin is extends to more proximally from where the left gastroepiploic is there, then we might also have to ligate the short gastric vessels.
No, actually, you have to, if you do proper T2 dissection, you have to go to the first the lymph node sites of 1 and 2 in the cardia, and then you come back lower down to identify the splenic artery. And from splenic artery, the origin of this thing, the gastroepiploic like 4SA, SB, and 4D nodes, along the greater curvature, you will dissect. You know there is a junction between the right gastroepiploic and left gastroepiploic artery. That is your limit of dissection, removing the lymph node in the greater curvature. That is the thing. So then, not that the whatever you extent of dissection is there, because you are describing, I think, the subtotal gastrectomy, not the total gastrectomy, right?
Yes, sir.
So once you have done this, you are coming now towards the lesser curvature side.
Curvature.
Start.
Sir, the lesser curvature, sir, we first start with the gastrohepatic ligament, sir. We release the gastrohepatic ligament, and this is, sir, released from close to the porta hepatis, sir. And sir, the right gastric artery would be found here, which is also ligated. It is ligated close to its origin.
You can't get easily the right gastric artery. You have to have identify either the common hepatic, follow that to identify rather proper hepatic artery. Either if you don't identify the proper hepatic artery, you cannot identify the right gastric artery. That is the trick of doing this. Which station lymph node you were removing there in the hepatic artery proper?
So proper hepatic artery.
12.
Okay. 12, sir.
And right hepatic artery, right gastric artery is lymph node station?
Just region of suprapyloric area.
Suprapyloric. Which one?
Suprapyloric. 5, sir. 5.
5. Right.
So once you divide the lesser omentum from porta hepatis down to the stomach line, you will find the hepatic artery.
Yes.
And as the hepatic artery bends up, to become
So
hepatic
the
artery
right
proper.
gastric artery is released from there.
Yeah.
Originates from there.
Yeah.
There are two arteries. There, GDA is more powerful artery from there, and also the
Right gastric artery.
right gastric artery.
So here, so at the near close to the origin from the hepatic artery, we will ligate the right gastric artery.
Yes.
And so once the right gastric and now so the right gastric and the right epiploic both have been ligated, so we can divide the duodenum from the stomach, sir.
Yeah. So you have to make a tunnel. You have to make a tunnel around the pylorus and the first
around the
duodenum.
pylorus in the first part of the duodenum. Sir.
Yeah.
So is one important steps you have missed, or also we have missed that before doing this procedure, you have to do a proper wide cauterization. Otherwise, you cannot do this. No? Right? Cauterization you have to
Duodenum
do.
cauterization.
Otherwise,
While mobilizing the pyloric area and mobilize the first duodenum, we also do a good cauterization.
Good cauterization. Good cauterization.
So then we divide the duodenum. So
Where is your line of transaction? There is no subjective. Everything should be objective. You have to say like this. I'll cut here.
So it is.
Is the antral growth. It's antral growth where do transect distally.
Yes.
So it has to be just beyond the pylorus, sir, and including the subpyloric and the suprapyloric lymph nodes.
No. Be sure that it is your objective goal. You have to cut the 2 centimeter from pylorus and just right of the CBD.
Okay.
So this is, sorry, left of the CBD. Very, very important. Left of the CBD. Otherwise, you may injure the CBD or like that. So this is 2 important point. 2 centimeter is 1 point, and 1 point is left side of the CBD. This point should be in mind because CBD is exposed that time, no?
Yes, sir.
Now.
Once we have we can ligate the we can resect the divide the duodenum and the stomach using a stapler, sir, a linear stapler.
Yes.
What stapler you use?
So we use a blue stapler, sir. 60 mm.
Stapler or it's a cutter?
So it's a cutter, sir. Linear cutter.
Linear cutter.
Yes, sir.
So you can use a 55 or 65 linear cutter.
Linear cutter.
Yes.
Blue is good enough for a duodenum.
Yes, sir.
So it staples and cut.
Yes, sir. It will staple both the ends, sir, and will cut the.
Fine. Then what do you do? Now that duodenum is divided. What is the next step now?
So then we would go for the dissection of the lymph nodes, sir.
Yes.
So in the sir, we would sir, the stomach that has been divided, sir, we would lift it up, and the lymph nodes that are there on the gastric beds are dissected, sir. So this would include
gastric bed means I can't follow gastric beds. See, all the lymph nodes are along the named arteries or
yes,
unnamed.
Yes, sir.
So there is no gastric bed like this. Gastric bed is pancreas, so gastric bed is not there.
Sir, these would be the lymph nodes along the hepatic artery, sir, which would
be
common
hepatic artery. Common hepatic artery.
So
sir, you have to identify common hepatic artery and go along the common hepatic artery up till
its origin, sir.
Celiac trunk.
Yes, sir.
And then that is 8. Where is 7?
That is 8. Right. That is 8.
Yes, sir. So 7 is the left gastric artery, sir.
So dissect around the cardia.
Yes, sir. Around the cardia
to find the left gastric arising from the celiac trunk. It's a very short vessel.
Very short. Before that, you remove the 8A, rather 8 anterior. 8B posterior may not be removed before getting the left gastric artery. You will encounter left gastric vein, which is the stout one, which should be ligated first. Then you go ahead above, and then you get the left gastric artery. That is the thing. If you remember that the left gastric vein comes first.
Okay, sir. And sir, then the remaining would be the lymph nodes along the splenic arteries, sir, which are dissected till the hilum of the spleen.
Yes, yes.
What is the landmark for the splenic artery? If you take the pancreas as a landmark, where is the splenic artery?
Sir, it will be along the superior border of the pancreas, sir.
Yes. And go up to the hilum of the spleen.
Hilum of the spleen, sir, which would be station 10 and 11, sir.
Yes.
So once we have done this, we would go for the resection of the stomach, sir. So this resection, sir, the proximal extent, sir, would be at least 6 centimeters proximal to the proximal margin of the tumor. Sir, again, sir, I would like to use a linear cutter to resect the stomach at this point, sir.
Yes, and in this resection, most of the time, almost whole of the lesser curvature is taken off.
Taken off, yes, sir.
It is close to the cardia, because if you take 6 centimeter, almost the whole lesser curvature comes in resection.
Yes.
Okay.
Yes, yes.
Yes, sir.
So now you have translated the stomach. What is next? How do you reconstruct?
Sir, next would be the anastomosis, sir. Sir, I would like to I would like to do a gastrojejunal anastomosis, sir, and this I would like to do using a linear cutter and stapler. Sir, the loop of the jejunum, I would bring it from the um, uh,
Why do you take the loop?
Sir, the loop is taken on 25 to 30 centimeters from the ligament of Treat, sir, from the DJ junction, distal to the DJ junction. Sir,
yes. How do you achieve the anastomosis?
sir, the loop is brought, and so the loop is brought and placed next to the dissected part of the stomach. Sir, I would like to use a stapler. So, sir, I would after placing both the jejunum and the
You
stomach.
tell us clearly. You are doing a anticolic or retrocolic anastomosis.
Retrocolic, sorry, sir. Retrocolic.
If you are doing retrocolic, there is a step to go.
Yes, sir. We will have to create a rent in the retrocolic compartment, and through this we bring the jejunal, just the loop of the jejunum to the supracolic compartment. So after this, once both the jejunum and the stomach are placed next to each other, we would make a small we would make a gastrotomy and a jejunotomy. We would apply a stay suture at the distal extent till which we want
So
the
apply stay suture first before you make the gastrotomy and jejunotomy. Stay suture should be applied first.
So we would apply the stay suture first to the up till which would be at the distal margin of the distal extent till where we want the anastomosis. Then we make the gastrotomy and the jejunostomy, through which we introduce the stapler. So once the stapler is introduced and we are ensured we place the proper surfaces, we align the proper surfaces face to face, and then we fire the stapler, sir. Once after removing the stapler, we check the line of anastomosis, and once we are sure, we close the enterotomies.
Both gastroenterotomy. There will be remaining part of gastroenterotomy, which should be closed in either single or 2 layers.
Yes.
What next?
Yes.
You have made a rent in the mesocolon.
Yes, sir. So this rent will have to be. We will. So this rent we'll close this rent, sir. But so what we would I would like to pull down the this anastomosis that we've done into the infracolic compartment, and then I would like to close the mesocolic rent.
Yeah. So you apply interrupted stitches between the stomach wall and the mesocolic rent.
Mesocolic, yes.
Okay.
Okay, so again, if you recapitulate the carcinoma stomach from the beginning, apart from the D2 gastrectomy, we have to some newer points in the guidelines. There are the NCCN guidelines. So nowadays, there are 2 or 3 things you have to remember, that all CS stomach cases, on the assessment before operation or before any treatment, you have to do MSI or MMR. This is included now in guidelines. And the pathology important point is not the Borman classification, but the Lauren classification is very important, so that you will know that it is an intestinal type or not,
Yes, sir.
or
Yes, sir.
diffuse type. Why it is important to know that it is intestinal type?
Sir,
Because Lawrence type, that is Lawrence classification, the intestinal type may secrete the HER2. So there is the scope of immunotherapy, right?
okay, sir.
Okay, so HER2 test is mandatory when the pathology report is intestinal type. Number 2. Number 3 is that you have to do the endo-EVAS whenever you think that it is a very early gastric carcinoma. If it is on CT scan, it is a advanced disease or locally advanced disease, you don't need to do this endo-EVAS. And as you know that whenever the T stage goes to the muscularis, then you have to go NACT most of the cases. This is the standard care. Okay. So now, as there is a long fight between the East Asia, like China, Korea, and Japan, and the Western countries, because CS stomach. So even if today the NCCN guideline says that the localized carcinoma, you can do the D1 plus, or this called the modified D1.
Yeah.
So this is they have included with D1 lymph node dissection 8A, not the HP, 9 and 11. 11, you know that it is the retroperitoneal lymph nodal mass when you mobilize the celiac trunk only. And when you do the total gastrectomy for this, you also add this thing, 8A, 9 and all those things. So these are the way they have made this thing. But if you answer in your exam that what is the curative treatment of CS stomach, you can jolly well say yes sir, D2 gastrectomy.
Okay, sir.
And Milind, there was earlier description of resecting the tail of pancreas and spleen.
Yes, sir.
What are the situations where you might need to resect the tail of pancreas and the spleen also? It's not done routinely as part
no,
of
sir.
D2 gastrectomy. But there are some situations where you might need to consider doing a distal pancreatectomy. It means the tail of pancreas and the spleen.
Sir, I'm not sure about.
So in carcinoma of the body of the stomach,
Yes, sir.
when there is infiltration to this pancreas, now standard of care is giving neoadjuvant. But even
Yes,
in
sir.
neoadjuvant, if there is invasion to the structure, you can take off the pancreas tail and the spleen.
Please.
Yes, sir. Only the literature says only the Japanese, Chinese, and Korean surgeons they do the pancreatectomy.
No, that was routine earlier. That was earlier routine in D2 gastrectomy. Now then modified to that you need not resect the pancreas.
Modified, and they remove very well the lymph node station 10 without the spleen.
But still, if you now still have invasion in the structure, then you have to consider doing this.
Yes.
Milind, what is the post-op management of patient following gastrectomy?
Sir, in the post-op, sir, first of all, sir, I would like to ensure that the Riles tube that we have inserted is placed beyond the site of anastomosis. So this would help us, as we would, if you want, we could start early enteral feeding for this patient.
That means you want to put the right tube beyond the GJ.
Yes, sir. Yes, sir. Beyond the GJ, sir.
So this will act as a nasojejunal tube.
Yes, sir.
Okay.
So other than that, sir, sir, so
So patient should be on IV fluid.
yes, initially, sir. Initially, the patient would be on IV fluids. So I would like to put the patient on so 5D and a balance of 5D or DNS along with, so to ensure that the glucose requirement is met, along with an isotonic fluid such as NS. Yes,
What
so
is the recommendation to start oral fluid in a patient who has undergone gastrectomy? You put a nasojejunal tube, you can start early enteral feed also, but when do you start oral feed? Is the era of
eras, sir, early
eras.
sir.
So people are starting oral feed as early as same evening or by next morning. Okay.
Yes, sir.
What is the concern? Do you put a drain? Following gastrectomy?
If the gastrectomy is for in case of a cancer, sir, in case of a carcinoma, if we are sure that we have secured all bleeding points, and if we, sir, then I would not like to put a drain, sir, because
what are the proponents of drain people? They put drain for what? Only for bleeding or something else?
no, sir, also to detect leaks, sir, if there is a leak.
Which leak?
So
Which
the
leak
leak
is
from
more
the
common?
from the site, sir, from the gastrojejunnal site, sir.
GJ site. Any other
Yes.
site?
No, GJ side, nobody bothers about GJ side leak because these two are very
The high
vascular.
output, sir. It is a very
No,
vascular
No,
answer.
very
No.
vascular. So duodenum is important structure.
Yes.
Duodenum.
Duodenal stump blowout is a concern for
Yes, yes.
Okay,
in immediate posterior period. You see, this is most of the people will put a drain in the
HRP.
HRP to assess any duodenal stump blowout. Particularly if you have a difficult duodenal stump being managed, then
okay.
drain should be placed.
Please, yes,
Okay.
yes, sir.
Okay, you can discuss stump blowout in a different ward rounds in.
Yes.
Okay. You see now what is the role of laparoscopy in gastrectomy in cancer? Any observation? Is feasible? Not feasible? Oncologically not?
Sir, it's feasible. So laparoscopic gastrectomy is
Yes.
also done, sir.
Now
It
there
is.
are a lot of applications. People are claiming that you can have same oncological outcome following laparoscopy due to gastrectomy.
NCCN already included laparoscopy, gastric D2 gastrectomy allowed, and they also claim that better lymph node harvest. Oh, so Milin, what
sir.
is your optimum lymph node harvest?
Sir, 15 lymph nodes, sir.
No, 16.
Okay.
16.
So you started by saying that if the patient needs GJ, I'll do a straight open rather than laparoscopy.
Yes,
People
sir.
can do laparoscopic palliative GJ. So it's
Yes,
not a statement that if the patient requires a GJ, I'll go for laparotomy rather than laparoscopy. Laparoscopy is standard of care in most situations to exclude small peritoneal deposits, small omental deposit, and small liver deposits.
Yes.
Because if you found this, your management might change. If
Yes,
the
sir.
patient does not have outer obstruction, the standard of care in this situation is giving the patient neoadjuvant chemotherapy.
Yes.
And then go for surgery. But surgery again will be palliative in this situation.
Yes.
Okay, Dr. Basu?
Yes, sir.
There is no question in the chat box. We can conclude.
Okay. Milind,
Any special point you'd like to mention?
No, not any special mention. Already all special mention maybe
Yeah. So
discussed.
one should be conversion in the lymph node stations. How does the lymphatic stomach drains? So
Yes.
because unless you know the lymph node stations, you cannot
Yes.
describe the D1, D2 gastrectomy. Okay.
Yes.
Okay. Thank you
Okay.
very much.
Thank you.
Thank you, Milind.
Thank you, sir.
Thank you, Dr.
Thank you,
Bhatt.
sir.
Thank you.